We have an interesting session in front of us because it's entitled Lung Cancer, Not Just One Disease. We're going to start with the LUME-Lung result about this drug nintedanib.
I'm really proud to be here, and I'm also very happy to start now with LUME-Lung. So this is really the first trial looking on the efficacy of nintedanib, and I think these are really exciting results. We are able to identify certain mutations in a limited group of patients, but we also have the other patients, and this is the majority. Most patients with lung cancer are diagnosed with an advanced stage of disease, and all of them are candidates for systemic treatment. And we have to say that all of these patients will suffer from progress of the disease at one point of time, and they will be in need of an efficacious second-line treatment. We have performed various trials looking on new compounds, looking on new combinations, but we were not able to show any improvement of overall survival for a new combination compared to the old therapeutic standard of docetaxel. In the LUME-Lung trial, patients with pretreated advanced non-small cell lung cancer were investigated. And these patients were randomized to a therapeutic standard which consisted of a chemotherapy with docetaxel plus placebo, or they were randomized to an investigational combination which consisted of docetaxel again combined with nintedanib. And the primary endpoint of the trial was delay in tumor growth, progression-free survival, and the secondary endpoint was improvement of overall survival. The main inclusion criteria consisted of a confirmed non-small cell lung cancer of advanced stage, but all histologies were allowed to enter the trial. So patients with adenocarcinoma, but also patients with squamous cell carcinoma were allowed to enter the trial. Looking on the primary endpoint, and this was delay of tumor growth, progression-free survival, a significant improvement of progression-free survival in favor of the combination of nintedanib and docetaxel was achieved, corresponding to a hazard ratio of 0.79 or a risk reduction of 21%. And this was true for the overall population, which means this was true for patients with adenocarcinoma as well as for patients with squamous cell carcinoma. If we look on overall survival in the overall population, there was no statistical difference between both of the arms. There was a numerical prolongation of median survival time from 9.1 up to 10.1 months. However, if we look on overall survival in patients coming from the largest subgroup of lung cancer, and these were the patients with adenocarcinoma, in this group, there was a significant improvement of overall survival with a prolongation of the median overall survival from 10.3 up to 12.6 months, and this benefit in overall survival was consistent. So we did observe an improvement of the one-year survival rate from 45% up to 53%, but we also did observe an improvement of the two-year survival rate from 19% up to 26%, and these are data that we have never seen before in second-line treatment of patients with advanced lung cancer. What about tolerability? Well, the most frequent adverse events that occurred by the use of nintedanib and docetaxel were gastrointestinal side effects like diarrhea and nausea, or liver-associated side effects like a transient elevation of liver enzymes. However, there were only very few side effects of severe degree, and most of these side effects were completely reversible. So in summary, the LUME-Lung 1 trial met its primary endpoint. We did see a significant improvement of progression-free survival in the overall population, corresponding to a hazard ratio of 0.79. Furthermore, in the group of patients with adenocarcinoma, we did observe a significant improvement of overall survival with a prolongation of median overall survival from 10.3 up to 12.6 months. And to my knowledge, this is the first trial which showed a significant improvement of overall survival for a combination of an anti-angiogenic agent and chemotherapy in a pre-treated group of patients with advanced lung cancer. So, with regard of the clinical implication, patients with the most common form of lung cancer, that is adenocarcinoma, lived longer when nintedanib was added to our standard second-line chemotherapy of docetaxel without any substantial side effects.
I am the professor of the thoracic surgeon, and I come from the Guangzhou, Guangdong. So this device, we are focused on patients harboring the EGFR mutation. So in these clinical trials, the comparator is the chemotherapy, the gemcitabine plus the cisplatin. So gemcitabine and cisplatin is the standard treatment in the Asia. All the patients come from the East Asia, including the China, Thailand, and Korea. And this study met is the primary endpoint. The patient on the afatinib lived for almost 1 year before the tumor start to grow again. The POS in the afatinib about 11 months, the chemotherapy 5.6 months. So this afatinib treated patient experienced the significant and the subtended tumor shrinks versus the chemotherapy. So this is independent review showed 67% patient experience the tumor shrinks. This means the objective response. But chemotherapy arm, only 23% patient saw the tumor shrinks. So median duration by the independent review for the afatinib, 9.7 months, but for the chemotherapy, only 4.3 months. This slide shows you more the patient taking afatinib experience the disease-related symptom improving than one the chemotherapy. Just you know, for the lung cancer patient, 3 important symptoms. One is the cause, one is the dyspnea, and one is the pain. For these 3, the primary symptoms, afatinib arm shows a very good response. This is about the saved data. In the afatinib arm, more the patient experience the diarrhea, drug-related ACE, and the stomatitis, mucositis. But in chemotherapy arm, only most patients experience the GI, the SE, such as vomiting, nausea, and the neutropenia. Take the afatinib arm, only 60% patients due to the drug-related and the reduced dose. But for the chemotherapy arm, 40% patient discontinued rate due to drug-related AE. So in summary, LUX-Lung 6 shows that the lung cancer patient on the afatinib live for almost 1 year before their tumor start to the growth, compared to just under half the year for the patient on the chemotherapy. Importantly, 1 year after the treatment initiation, almost half the afatinib-treated patients were alive and had not yet experienced disease progression. Almost all the patients had progression in the chemotherapy group. The afatinib-treated patient experienced the significant and substantial tumor shrinks, but chemotherapy with the gemcitabine and cisplatin. The patient on afatinib report an improved quality of life compared to those on the chemotherapy. Afatinib treatment was well tolerated with a lower discontinuation rate. This currently means LUX-Lung 6 added to the growing evidence of the superiority of the afatinib over standard of the care of the chemotherapy in the EGFR mutation positive non-small cell lung cancer patient. So I would like now to hand over to Professor Yang.
My job today is to put LUX-Lung 3 and LUX-Lung 6 studies together. This slide shows you two study designs. The study designs were very similar. Patients must have EGFR mutations. And then they were randomized 2-to-1 to receive either afatinib or chemotherapy. The only difference between these two studies is a comparator. The comparator for LUX-Lung 3 last year was cisplatin and pemetrexed. And for LUX-Lung 6 this year is gemcitabine and cisplatin. Both chemotherapy regimens are standard regimens for adenocarcinoma of the lung. LUX-Lung 3, as opposed to LUX-Lung 6, which was a major Asian study, was conducted globally. And when we look at these two studies, these are so-called Kaplan-Meier curves. I'm not sure whether you are familiar with these two curves. The horizontal axis represents the time in months, and the vertical axis represents the percentage of patients who stay in the treatment. So the green line here represents patients who were in LUX-Lung 3 who received afatinib. As you can see here, the patient who received afatinib was the yellow line, and the yellow line actually overlapped completely with the green line. So this is a very robust data telling you that whether these patients who had EGFR mutations were born in China or born in the United States or born in Europe, anywhere in the world, when they receive afatinib, they will have very similar outcomes. These are the numbers that we deduced from these curves. Several numbers that I want you to pay attention to. One is so-called progression-free survival time. This is the median time when a patient receives the drug until their tumor regrows. So the numbers for LUX-Lung 3 was 11.1 months. This is for all comers in the study, that is patient with EGFR mutations. And that the numbers for LUX-Lung 6 this year was 11.0 months. So almost identical number. This is a percentage of patients who had significant tumor shrinkage. That means our definition of tumor shrinkage. So this number for LUX-Lung 3 was 56. For LUX-Lung 6 was 67. And it was lower for patients who received chemotherapy. And the other way to measure the efficacy of the drug is to measure the lung cancer-related symptoms. As you can see here, the green line and the yellow lines are the patients who receive afatinib. And the blue line, violet lines are the ones who receive chemotherapy. And the longer lines means, longer columns means that more patients, more percentage of patients who had improvement in terms of their symptoms compared with chemotherapy. So this is a very simple graph that tells you that for patients who receive target therapy, afatinib had better symptom improvement compared with those who receive chemotherapy. This graph is even more complicated, but I just want to mention to you that patients who receive afatinib had better quality of life improvement in several domains that we measured compared with chemotherapy. As you can see from here, the higher grade side effect of diarrhea, 14% were seen in the global study, and it was less in the Chinese or Asian study. So in summary, LUX-Lung 6 and LUX-Lung 3 show the great evidence of the superiority of afatinib over standard of care chemotherapy. And both LUX-Lung 6 and LUX-Lung 3 in afatinib treated patients experience a long time delay in tumor growth, up to a year, and show a significant tumor shrinkage, which translates into improvement in disease-related symptoms. And the quality of life that we measured in patients who receive afatinib was better than patients who receive chemotherapy. And adverse events with afatinib treatment in LUX-Lung 6 and LUX-Lung 3 rarely lead to discontinuation. Actually, the rate was less than 1 or 2% in both studies.
So now we've been talking about the present and the near future, and now we're going to talk about where we're going with all these new targets.
Boehringer Ingelheim is known to you as being family-owned for more than 125 years in the pharmaceutical business. In addition, we have already collected more than 70 years of experience in developing drugs for lung diseases. Our drugs to treat emphysema or COPD, asthma, like Aludrin, Atrovent, Berodual, Combivent, Spiriva, have set up standards for treatment of these diseases, and now we extend our indication spectrum with lung cancer. So what I want to tell you is more about our pipeline and what comes after afatinib and nintedanib. Is there something more to know? And also, can we as Boehringer establish us in the oncology area more permanently? Why am I so confident? We have a very strong scientific research site in Vienna with dedicated scientists, 250 of them, that only work on oncology drug discovery. And we have multiple collaborations, alliances ongoing, and also interactions with the Basic Research Institute, the Research Institute of Molecular Pathology in Vienna. Our research targets focus currently on 4 important hallmarks of cancer. This is signal transduction, so tumor growth signaling, tumor angiogenesis, of both you have heard already today. In addition, cell cycle progression and immunotherapy. And we, as you can see, we're also proud that we can show that we have been successful with clinical candidates for clinical development in all of these 4 areas. You know about the tip of the iceberg, afatinib, nintedanib, perhaps also volasertib. In addition, we have 7 more compounds in phase 1. Some of them will pretty soon also hopefully move towards phase 2. Overall, it's 10 compounds, and they are nicely balanced. 5 compounds are small molecules, and 5 compounds are antibodies. We are now not only developing our drugs in lung cancer, but we have a very broad spectrum of trials set up for all the compounds in non-small cell lung cancer, ovarian cancer, but also in addition in leukemia and lymphomas. Let me now come to the conclusion. We are committed at Boehringer Ingelheim to improve the lives of cancer patients. We want, with the primary focus right now, advance the treatment of lung cancer, addressing different unmet needs in lung cancer with afatinib and nintedanib. We are also very much interested to study rare diseases. We show that, for example, by developing volasertib in AML or also nintedanib in other very devastating lung disease, idiopathic pulmonary fibrosis. We are currently delivering, as you know, results. 14 data presentation at ASCO. 4 abstracts have been accepted for oral presentation here. So right now I think we all can be very grateful to our teams, the patients and also the investigators who help us to move our compounds closer to the patients.